thank you to everyone for attending this first webinar in a series of 4 sex relationships and the SCI Man. This first webinar is with Damian, and I'll introduce him formally in a sec. The next 3 over the next 6 weeks or so. The next one is with some spinal cord injured men talking about their personal experiences. After that, it's to go with their partners. And then after that, we've got Michelle Donald, who is a psychosexual therapist who will have reviewed all the seminars, given her overview, talking about case studies, making sex and relationship work after a spinal cord injury. But today, we've got Damian Smith, who is SCI nurse specialist at the SIA, speaking to us, and we're kicking off with the physical side of issues following a spinal cord injury. Damian has so much experience before arriving at the SIA. We were just chatting about him treating a patient 20 years ago in Salisbury, where he was for 25 years before moving across to the Spinal Injuries Association, where he is now. Obviously, the Spinal Injuries Association has helped enormously with Bolt Burdon Kemp putting on these webinars. So without further ado, I will hand over to Damian. Thank you very much.
Thank you, Tom. And yeah, thanks very much for coming along today. It's really great to see so many people here. So Tom quite rightly just said, I've got quite a bit of experience about spinal cord injury. I worked at Salisbury Spinal Centre for 25 years as a clinical nurse specialist there. Most of that time in the outpatient department and seeing patients once they've been discharged from hospital and providing follow-up support and advice, which we provide lifelong support for all of our patients, and covering any aspect of spinal cord injury, whether it's bladder, bowels, including sexual function. And before I put the presentation together today, and this is a brand new presentation for you, I've talked about sexual function quite a few times before, and almost to the point where not that I was the go-to person to be talking about sexual function for our patients, but we do recognize there is an area that doesn't widely get talked about for various reasons, whether it's because somebody doesn't feel comfortable talking about it. We seem to be very comfortable talking about bladder and bowels and skin, and sexual function tends to get sort of pushed a little bit further down that road. But it is very, very important that it does get discussed, in the same light. It should share equal, have equal airtime, if you like, as far as, when we do talk about all the issues that encompass the impact of spinal cord injury. And I think, often, for a lot of our patients, and I'm thinking more about the demographic when I first started working in the spinal unit, they were young men. Often, the average age was about late 20s, some in relationships, some that weren't in relationships, some that have never been in a relationship. And to have a spinal cord injury, the impact that has on their self-esteem, how they feel about themselves, is really, really significant. So it is a very, very important topic to discuss, and there's not a great deal of information that patients can just go to, or same for healthcare professionals as well. But I think, having an open, honest conversation and a sensitive conversation, with our patients, with other healthcare professionals, will help break down some of those taboos that, some people still associate with talking about the issue of sexual function. So I have got a presentation, and I'm not going to bamboozle you with too much anatomy, physiology of the spinal cord. But I think it is important just to talk about a few of the key points, because that will just make it a lot more relevant when we talk about the physical aspects of spinal cord injury and how that impacts on sexual function. So I'm before
you get started, sorry, Damian.
Yeah.
There'll be time for questions at the end. I don't know if you were just about to say that, but if you want to put your questions through on the chat function or the question and answer function as we go along, then at the end, if Damien hasn't covered it, there'll be plenty of time to go over everything. Sorry, Damien, back over to you.
No, thank you. Yeah, but yeah, do feel free to ask questions. Hopefully I'll cover the majority of what it is that you're expecting from this session. But, if there are things that I haven't perhaps explained in enough detail, by all means, do just ask. So I'm going to go ahead and share my screen. And so can I just check that everybody can see that title slide up on the screen okay there?
Looks fine to me, so it should be for everyone else.
Okay, brilliant. Thank you. So yeah, just very quickly, just to go over, what my previous role was. Again, I worked in the spinal unit for 25 years before, coming to the Spinal Injuries Association back in November of 2020. I have to keep remembering that we've entered a new year now. So, a lot of my role was dealing with outpatients, but I also used to run the consultant clinics as well. I was running a nurse-led cord recliner clinic at the spinal center, which had no consultant involvement at all. It was a purely nurse-led service. But I was also involved in a lot of the training and education at Salisbury Spinal Unit. And right in the middle of the pandemic, when the pandemic hit, my role changed quite significantly. So I did take on a lot more of the education. And I thought it was very, very important that during the pandemic when everybody was stretched, whether that's the nursing staff, certainly education in the form that we used to present it had to change because we couldn't have big groups of patients all in the same area. But also as well, we're very conscious of the fact that it's not just educating the patients, it's educating the friends, the relatives, partners about everything that we want to try and convey to the patient. Because if they can be as informed as possible, I think it gives them a lot more understanding of the impact of having a spinal cord injury. So I did run a very similar session to this for patients, staff, and relatives all in one go via the use of technology. And it just worked really well because we reached a point where all of a sudden the education had to stop for various reasons. But, how could we get it back on track just to make sure that patients got the best experience and the best sort of knowledge, education. So I think now, working like this has become almost part of the norm. I'd much rather, to be honest, give a presentation face to face so I can actually see the people that I'm talking to and be a bit more interactive. But we've got these tools at our disposal, and it can still work very effectively. So I will progress with the presentation. And the first thing to say, and I guess this is a really obvious statement, right there in that title, that, spinal cord injury is a major life-changing trauma. Most people, I can say, confidently, their lives were very, very different, before they had their spinal cord injury. Although we do come across children with spinal cord injuries that they don't know any other life. For the majority of the patients that we do see, their lives were very, very different as able-bodied patients. And just to take you on a little bit of a journey in those early stages, somebody has a spinal cord injury, and it is a devastating event in their lives. But if they come into a spinal center, which not everybody does, we are dealing with a lot of patients in district general hospitals, major trauma centers. But for those that come into spinal centers, there is a lot of sort of peer support, from just being in an environment where they've got other people with similar conditions. But that doesn't take away the fact that their life has changed. we bring them into hospital. One of the first things that we do is strip them off naked. The reason for that is because often they're on bed rest for some period of time. Having them naked makes it a lot easier to be able to check their skin, to monitor for things like pressure ulcers. But we're very aware that, if you strip away their clothes, you're stripping away some of their dignity, and that's often the perception. But as much as we try to protect somebody's dignity, it's not always possible to do that in the way that the person would like it to be. There can be this sense of, change of body image, because, I've spoken to patients before that when they're in bed, often, well, it's difficult to see the the disability, because they could be anybody that's in bed. I think that change in body image can often occur, at the point where that patient is told, right, on this day, we will be getting you up into a wheelchair for the first time. Seeing that wheelchair really sort of hits home that actually, things have changed. And someone's perception of how they are now compared to how they were before can be quite different. I think the reality starts to dawn on them that they do have a disability. That you can't get away from the fact that a wheelchair is a symbol of disability, whereas some people will argue, well, it's also a symbol of enabling people to do the things that they want to do. But there might be this loss of identity, the fact that their body becomes public property. And what I mean by that is that for a lot of people, they might be more dependent on the healthcare professionals to do everyday tasks for them, whether that's getting up into a wheelchair, assistance with personal hygiene, assistance with bodily functions like bladder or bowel management. And just part of the initial assessment, when you do a neurological assessment, that can be invasive as well. The doctors having to put their finger inside the patient's rectum, to check for spinal reflexes. It's a lot to try and take on board, when you have this significant spinal cord injury. But as the patients start to progress, maybe some of them will be able to be completely independent, but the things that we took for granted, day to day, they might just take a little bit longer. It might take a lot more effort to do those basic things like, getting themselves washed, dressed, up into their wheelchair. Whereas, we probably take it for granted that the alarm goes off, we jump out of bed, jump in the shower. It can be a relatively quick, process, not taking up a lot of energy. But for some of our patients, that whole process, by the time they've done that, it can be a massive drain on their energy. And today, we're talking about sexual function, but if you've spent maybe an hour, 2 hours getting yourself ready just to get up in the morning, that lack of energy can be really telling for somebody. But I think before we progress and talk about the sexual function side of things, I just want to do hopefully what is just a very, very simple explanation of what spinal cord injury is. And before we do that, we'll just talk about the spine itself, which is essentially the protective mechanism that protects the spinal cord within it. So, as humans, we have 7 cervical, 12 thoracic, 5 lumbar, 5 sacral vertebrae, and the coccyx. The coccyx is just a redundant part of anatomy that we've still retained despite sort of many, many years of evolution. But it serves no purpose apart from it can be quite painful if you injure it. But the vertebrae themselves, they do protect the spinal cord injury, and the human body is a pretty robust piece of engineering. But of course, we're not immune to damage, of any part of our body. But just to give you a sort of very brief explanation of, what it is that really we're looking at today, and the important parts of the spinal cord and the effects that it has when it comes to sexual function. I'll just quickly run through that. So the spinal cord itself is an extension of the brain, and it travels down through the cervical vertebra, thoracic vertebra, and it finishes around this area here. So if we just go back to the previous slide, I'm very aware that I don't want to sort of talk about, use too much terminology that may be unfamiliar to you. But when we're talking about somebody's level of spinal cord injury, we tend to use the first initial of whether it's, cervical, thoracic, lumbar. So say, for example, if someone they've damaged their fifth cervical vertebra, we'll refer to that as a C5 spinal cord lesion. And, if it's the sixth thoracic, T6. So hopefully, that will just, help clarify, some of the terminology that we might use. But when it comes to the spinal cord here, it ends at this point here, and this is the conus medullaris. And I don't want to sort of bamboozle you too much with, again, just some of this terminology, but the important part of the conus medullaris is that this is the reflex center of the spinal cord. And reflexes are really, really important because even if someone is completely paralyzed, if their reflexes are intact, their body will respond in a reflex way. And, one example of a reflex is if you go to touch something hot on the stove, automatically, without thinking about it, your hand will move away from it. Because what's happening is you've got sensory nerves and motor nerves. The sensory nerves pick up that sensation of heat, fire off to the spinal cord, cross over through an intermediary neuron, and fire off a motor neuron, which causes the muscle to contract. And that's a reflex, very, very simply. So bearing that in mind, if we know where someone's level of spinal cord injury, that'll give us an idea of what their sexual function potential might be. So essentially, anybody with a spinal cord lesion above this level here, and this is roughly about T12 to L1 level. It does vary because, anatomically, we're not all the same, but it's there or thereabouts at the sort of T12, L1 level. So someone with a spinal cord injury above that level, really we would expect their reflexes to be intact. And as we go through the presentation, I'll explain, what that means in a practical sense when it comes to sexual function. But below that level, you have the cauda equina, and cauda equina is a Latin name, and it literally translates into horse's tail. But below that level, if someone has what we would refer to as a complete spinal cord lesion, and we often talk about complete or incomplete. Incomplete means that there might be some sensory or motor sparing below the damaged area. If they're complete, that means that there's no motor or sensory function below that level. But if someone has a complete spinal cord lesion, then it gives us a better idea of how we can perhaps predict what type of sexual function that individual will have. And, we can sort of tailor the advice accordingly. But just going further down the cauda equina into the sacral spinal nerves, these are the really important ones for today, because it's the sacral nerves S2, 3, and 4 that control sexual function. But they not only control sexual function, they also control bladder and bowel function. So they're all intrinsically linked. And the fact that they're all down here, the importance of that, or the relevance, if you like, is that we very rarely see somebody with a sacral cord damage. The patients that we see tend to have cervical, thoracic, lumbar, or cauda equina nerve damage. So essentially, all of these patients, doesn't matter where that level of damage is, if you think that your spinal cord, the cauda equina, is your conduit for sending messages backwards and forwards to the brain and out to the various muscles, if you've got an area of damage, above this S2, 3, and 4, and to be honest, there's not a lot below that level, it's going to hit a barrier where the spinal damage is. So essentially, anybody with a spinal cord injury, you would expect them to have some bladder, bowel, and sexual dysfunction. So just to sort of put it into a bit more context, from a more sort of visual point of view, the spinal cord runs up through the middle of the spinal canal, through the vertebra, all the way down to the sacral level, where it's a little bit different there. But if I click on the animation here, you can see, the hole here, which is where the spinal cord will travel up, and the spinal nerve roots will come out at various points all the way down the body, to control, the arms and the legs and everything else. When you get to the sacral nerves, they feed through these holes in the pelvis and all join up above the level of the pelvis, into the cauda equina and then up. So I think when we talk about sexual function, I think it's important to talk about sexuality as well, because the two are linked, but they are quite separate. And when we talk about sexuality, what does that actually mean? Sexuality, that includes our genders, our bodies, how they work, our values, attitudes, beliefs, and feelings about life, love, and the people that our lives touch. It's how we perceive ourselves. We're living in a much more diverse cultural society these days, and I remember in the early days, talking to the guys about sexual function, and essentially we're talking about heterosexual sex. We've had to adapt and sort of modify, how we teach people, to make sure that, we include everybody that, we come across. And, we see lots of patients that identify in very different ways. Their sexual preferences might be quite different. Their sexual orientation is quite diverse as well. So when it comes to educating somebody about sexual function, it's very important to be respectful of their beliefs, so that we're not excluding everybody. We are very, very inclusive. That can be difficult to do when you're talking to patients in a group setting, and that tends to be how a lot of the patient education is delivered. But I'd always give people the opportunity that if they don't feel comfortable talking about something in a group, come and speak to me independently. And I'd always suggest that if they are in a relationship, come and talk to me with your partner as well, because for them to have that understanding of why somebody with a spinal cord injury, why things don't work in the way that you would expect them to, I think is really important that they're as aware as the patient that we're addressing these issues with as well. But someone's sexuality, it can be affected, the perception of their own body image, because it is, I've said it already, it is a life-changing traumatic event in somebody's life. Just to give a real stereotypical sort of cliched example, you might have, an alpha male that, was very confident in their own body, to go out, a weekend, to interact with, people that they're sexually attracted to, as an able-bodied person. But you throw spinal cord injury into the equation and disability, you have to take into account that the psychological impact that might have on them as well. It might affect their confidence. It might just affect how they perceive themselves. Do they still see themselves as sexual beings? From my experience, of the time that I've spent, looking after people with spinal cord injury, I can honestly say that it's primarily down to that person's personality about, how they feel about themselves. We can't always change somebody's personality, but what we can do is hopefully dispel, some of the fears that they may have about whether somebody would find them attractive or not. Whether that includes their partners if they're in a relationship already, or whether they're single and thinking, well, how am I going to get into a relationship now I've got this disability? It's never appeared to be an issue at all, other than a psychological issue that the person might feel about themselves. And I think that psychological barrier can be quite easily broken down. I say easily broken down. It is very easy to say that, but I've seen patients that have gone out and they're not necessarily looking to initiate a relationship or talk to somebody about just anything, life, but I think having a disability almost, it strips away some of the barriers that somebody else might have had, when they that they might have had when they were able-bodied. Patients have said to me that often they're not perceived as a threat, so people are sort of more likely to come up to talk to them and initiate a conversation about what happened to you, why are you in a wheelchair. That can be quite a sort of a brazen way of starting a conversation, but all of a sudden there is a conversation that has been started. The channels of communication have been opened. Some of those fears that somebody that is newly injured may have, all of a sudden they're like, well, actually they've approached me, they're talking to me. You can open that conversation and then just hopefully things will just progress and the conversation will just develop and that person will just feel more at ease about their own identity. But we certainly don't take that for granted. And of course, everybody deals with things at a different pace as well. But, we can encourage that by, supporting them to basically say that if you have a spinal cord injury, life doesn't just stop. You can have a rich, fulfilled life, and we can guide you through that. So when it comes to sexual function, as I mentioned, it's those sacral nerves, S2, 3, and 4, they're the ones that are responsible for, affecting sexual function. And when the nerve damage above is such that those messages are not able to travel back and forth, there's going to be a degree of sexual dysfunction, depending on the nature of somebody's spinal cord injury. So I mentioned just now about the conus medullaris, which is the reflex center. And the reflex center, if those reflex centers are still intact, without even thinking about it, those reflexes can still be triggered. And lots of patients will get reflex erections. And, that can be triggered just through those sensory nerves that are sort of traveling backwards and forwards, through S2 to S4. And that can be triggered in different ways. And, I don't worry too much about the terminology, but a reflexogenic erection basically means, an erection through physical stimulation. And that physical stimulation could be the fact that they may have an indwelling urethral catheter in, and just the fact that that catheter is in contact with the penis could be enough to trigger a reflex erection. It might be, when the nurse is assisting somebody, with a wash in the bed, just that physical stimulation of, washing around the genital area can trigger a reflex erection. I mentioned right early on that, one of the first things we do is, we strip our patients off. They're often in bed naked because it's easier to monitor their skin that way. But for some patients, just having the contact of the sheet against their skin can be enough just to trigger this reflex erection. Also as well, because spinal cord injury affects the bladder and the bowels, the way that somebody's bowel care might be managed through digital stimulation, manual evacuation, sometimes that digital stimulation can be enough to trigger a reflex erection. And that's always something that we make our patients very, very aware of, that, we don't want them to feel embarrassed. We want them to understand, why it is that their body's behaving in a certain way. And, I've had patients myself that, I've been, supporting, getting them washed, dressed in the morning, and all of a sudden they've got an erection, and you can almost imagine the thoughts that are going through their head. And, I'd be very quick to say, look, the reason that you've got this erection, I say, is probably because of the physical stimulation of just, having a wash. And hopefully that will just reassure them that, that's all it is. But also as well, that could be quite encouraging for them to think, well, actually, I am able to achieve an erection, because that can weigh quite heavily on somebody's mind. Will they be able to have sex again? And if you can get a reflex erection, that can be used to the patient's advantage. They might not be able to maintain it, but as we go through the presentation, I can explain, what devices and medications might help. So a reflex erection is one way, but there is another way as well. And the medical terminology for it is a psychogenic erection. But basically what that means in practice is that it's thought induced. So if someone's having, sexual thoughts, then, that can trigger an erection as well. So that can be used to the patient's advantage. I think trying to maintain a psychogenic erection isn't always that easy because it takes probably a bit more concentration. If you start thinking about what you're going to have for dinner that evening, then it might not be quite as effective. So using the two together, a reflexogenic erection and a psychogenic erection, that can all help. The psychogenic erections, I think, the person does have to be in the mindset for that to be sort of most effective, and there can be a lot of anxiety behind whether they will be able to get an erection or not. But because we're dealing with patients that will have some bladder or bowel dysfunction, we have to take that into account as well when we're talking about sexual function, that if the patient's got a urethral catheter in, can they still have sex? Well, the simple answer is yes, they can. But what you have to be aware of is that if someone does have a urethral catheter, I would still suggest that if someone is of a childbearing age and they're not looking to have children, you still take the same contraceptive precautions as you would have done, ordinarily. But you can still put a condom over the top of the penis with someone that's got a urethral catheter. But the way to do that would be wait until the penis is erect and then fold the catheter back along the shaft of the penis. If you put the condom on first, before the penis is erect, with the catheter pulled down the shaft of the penis, if someone were to get an erection then you can imagine that there might be some trauma to the glands of the penis, if they get an erection and there's not a bit of slack, with that catheter there. But to be honest, most patients with a spinal cord injury, a urethral catheter isn't always the best long-term option. We'd be looking sort of more at patients how they're having either a suprapubic catheter or an intermittent catheter, or some might use a condom sheath. And the patients that might use a condom sheath, they could have that for various reasons, but it might be that I mentioned about reflexes, that their bladder might work in a reflex way. So what that would mean in practice is that their bladder might reach a certain point, spontaneously empty. it's quite a good way to manage the bladder this way, certainly from an infection point of view, so long as the bladder does empty completely. But if you imagine you've got someone with a bladder that will feel spontaneously empty, you don't want this, sheath with this tap on the end of it when you're having sex. So essentially, you would take the condom sheath off, but then there is the risk that the bladder will just spontaneously empty. But there are ways to manage that. It might be that, to check that the bladder is emptied, that they can just pass an intermittent catheter to make sure the bladder is drained completely. So it doesn't matter what somebody's bladder management is. Ideally, you want to try and make sure that the bladder is empty, so there aren't any unwanted accidents. And it doesn't, whatever way that the bladder is managed, we can advise to hopefully prevent accidents from occurring. But they might be unavoidable. But I can honestly say that from the patients that I've spoken to, they are very, very rare. I think if you can talk, or if you can stick to your regular daily routine, with your bladder, your bowels, then you can reduce the risk of accidents from occurring. So a good routine will help. And, whether that's a bowel routine, I know I've certainly known patients that are quite anxious about the fact, will their bowels just empty? Particularly if their partner's on top of them, and they're having sex, just the pressure on the abdomen, or if they're having anal sex, you want to make sure that the bowel is emptied. Because if you've got someone that's having anal sex, just that stimulation around that external anal sphincter could be enough to trigger emptying of the bowels. So we might, we'd be talking to the patients about how their bowel management could be managed to make sure that the bowels are emptied beforehand, which sounds really clinical and can often take away some of the spontaneity behind it. But what we want to do is try and ensure that the patients have the best experience, and they're going to have a better experience if they can be more assured that they're not going to have an accident with their bladder or their bowels. So a good bowel routine, whether that's through use of suppositories, digital removal of feces, transanal irrigation, which can clear the bowel out a lot more effectively. It's all very much down to that individual. And that's part of, the assessment that we would provide. Understanding what their spinal cord injury is, how it impacts them, and, how it can be managed to suit different situations. But I think for the majority of the guys that I've spoken to, the big question that they want to know is, can I get an erection? Can I maintain an erection? If so, how do I do it? They're not worried about the physiology side of things, or most of them aren't. It's just, what can I do to get an erection? And I think times have changed. When I first started working at the spinal unit back in 1996, the options were limited. I'm not even sure that Viagra was an option back then, but when Viagra did come out onto the market, it sort of revolutionized the world of men with sexual dysfunction. But when it first arrived on prescription, it was limited to 4 tablets a month, and for some people, that wasn't enough. Thankfully now, it can be bought over the counter. The way that it works is that it helps dilate the blood vessels around the penis to help maintain an erection. It works much better for patients that have a higher level spinal cord injury, so above that conus medullaris, where they would get a reflex erection. So for someone that can get a reflex erection, basically what this does is help maintain it. So that initial reflex activity might stimulate the erection to occur, and the medication will help to maintain it. But like any medication, read the instructions on the box. Otherwise, it may not work effectively. So Viagra has a sort of relatively short lifespan. It sort of stays in the system for about 8 hours, must be taken on an empty stomach, nothing to eat or drink an hour before or afterwards. So again, it takes away some of that spontaneity. It does take a little bit more planning. If they've been out, perhaps, gone out for a meal, had a few drinks, come back and think, I'll pop the Viagra. It may not work effectively, or there may be a delayed effect when it's not wanted. But the medications have advanced as well. So things like Levitra and Cialis, they stay in the system quite a bit longer, sort of 24, 36 hours. You can eat and drink with it, so you can be more spontaneous. And I would never, say to a patient, this is what you should do, try this, do it this way. But I think for a lot of patients, they do feel under pressure that, if they're in a sexual relationship, that they want it to work effectively for them. But, I've had lots of patients that, they've tried the medication to see which dose works for them, before, they embark on, a sexual encounter, because it might be, in the picture here, this is a 100 milligram Viagra tablet, but, 100 milligrams, that might be far too much for what the patient actually needs. They might get away with 25 milligrams or 50 milligrams. But if they can try it on their own, hopefully that will just give them a bit more confidence and reassurance that, when they do have sexual intercourse, that they know what works for them. So again, that can take away some of that anxiety. And, when we're talking about the use of, psychogenic erections, to help get an erection as well, the more that that person feels at ease and confident that the medication is going to do what they hope it does do, I think there's a better outcome. One thing just to say about this medication is that the way that it works, because it does dilate the blood vessels, it's important to get advice about any potential interactions with any other medications that the patient might be taking. And for a lot of you that are here today, you may be aware of the condition called autonomic dysreflexia, which is the body's response to pain, below the level of the spinal cord injury, below T6 level. And the medication to treat that, if the cause can't be identified, has a very similar effect to these medications, in respect that it dilates the blood vessels. So, you do have to be aware that, these medications aren't going to interact with something else. And when we're talking about sexual function, the point of orgasm can be a trigger for autonomic dysreflexia as well. But the thing is with autonomic dysreflexia is that as soon as you remove the trigger, the symptoms will subside. And for those of you that aren't necessarily aware of what autonomic dysreflexia is, it's basically the blood pressure will go up and up and up until this painful stimulus is removed. So it can go up to a dangerous, even life-threatening level. But because a male orgasm literally lasts for a few seconds, I wouldn't say it's anything necessarily to worry about. It's just something to be aware of, that somebody might show those symptoms of autonomic dysreflexia for a very brief moment. But the medications, they do rely on physical stimulation to help initiate that erection, but they will just help to maintain it. But there are other options for people as well. This one, I think, whenever I've spoken to the guys about it, you can see, almost like a little tear in their eye, thinking, I don't fancy that idea much. But, there are different options for different patients. This is called Cavaject, and it's basically an injection into the sides of the shaft of the penis, which will dilate the blood vessels, again to trigger an erection. It's very important again that these patients are assessed properly, and that for the right dose, and also the right technique of where to give the injection, because what you don't want to do is give it into some of the major blood vessels, or any areas that you're not supposed to inject, like the top or the underside of the penis. It must be in these side parts of the shaft of the penis. And because it does dilate the blood vessels, having the dose, the right dose is important, because what you don't want is static blood to be in the penis any longer than it needs to be. Otherwise, there is the risk that that blood will clot, and that will require medical attention potentially. So far, these treatments are more for people with these higher level spinal cord injuries, those with the reflex centers intact. But for those that have a lower spinal cord injury, where those reflexes aren't intact, they would have what we would often refer to as a flaccid paralysis. So there would be no reflex activity within the penis at all. So the medication wouldn't work because there is no reflex to help trigger that. So one option might be something very, very simple, like a vacuum pump, which basically just the air gets sucked out of the chamber of the vacuum pump, which encourages the blood supply to the penis. But in order to maintain the engorged penis as it is, you have what's called a restrictor ring that sits at the base of the penis to stop the blood flowing back. And these restrictor rings, they do come in various sizes. And again, it's just very important that you get the right size for the right patient. So that really is, some of the mechanics, the sort of physical side of sexual function. But I think it's important to also mention about fertility, because certainly when I first started at the spinal unit, what we understood was that if you don't get sperm from that patient within the first 24 hours of their injury, then their sperm levels will just drop, and essentially they would become infertile. And you can just imagine that, you have a spinal cord injury and you're trying to deal with that, try and get your head around that. And then the doctor's tapping you on the shoulder and saying, by the way, do you want us to extract some of your sperm? Because if we don't, you may not be able to have children. Thankfully, we understand quite a lot more about the fertility side of spinal cord injury. That yes, sperm levels will drop, but the more that you can encourage ejaculation, and I'll talk about that a little bit in just a moment, the sperm levels will increase. But at the end of the day, you only need one sperm to be able to fertilize the egg. But obviously, you want to try and give yourself the best chance possible if you are going down the route of trying for children. And one way that can be done, a lot of centers do offer sexual function clinics where it might be possible to try out some of the equipment that is available. And these, they're both vibrators. They're both external vibrators. And I always remember the first time I took, one of these Ferticare vibrators out of the box, and it's probably, I don't know, maybe about probably about 10, 12 inches long. And the look on the guy's face is to think, where on earth do you stick that? Well, you don't stick it in anywhere. It's got a vibrating plate at the end of it, which just vibrates on the glands of the penis, and it's set at various frequencies, and you adjust the frequency to the level that's going to be effective for that individual. So it is important that they do get the right assessment to make sure that it does work well for them. In a very similar way, and I always think this looks like hair straighteners, and not that I've got much experience of hair straighteners, but again, they're just vibrating plates that you just very gently sort of squeeze against the glands of the penis, and that can help. It can help trigger an erection, but it can also help reflex ejaculation as well. So some patients, they do use these products, if they're looking to, increase, their sperm levels and the motility of the sperm. But not everybody, with a spinal cord injury will ejaculate, and or when I say they won't always ejaculate, they might not ejaculate out through the penis. A lot of spinal patients, if they are to ejaculate, they have what's called a retrograde ejaculation, where the sperm goes back up into the bladder, and the patient might not even realize that they have ejaculated. If they do, if they do ejaculate, it can take a lot more stimulation. It can take a lot longer. But it might be that the first that they're aware that they possibly ejaculate is that they might just notice that their urine looks different, and notice, that the sperm in the urine. But from a fertility point of view, sperm can be extracted from the urine and used, for, things like IVF. But another way of encouraging ejaculation is through, one of these electroejaculators. And I think initially these were devised as piece of equipment for endangered species. And I always remember one of our consultants in Salisbury, he brought in one that was used on elephants, and you can imagine the look of surprise on the patient's face, when they saw the size of that. But again, this needs to be used by trained clinicians. It generates an electrical current, and there is the risk, and it's a very real risk, of causing electrical burns inside the rectum. And I have seen that only once, but I have seen that previously. But so there are sort of tools at the disposal of the clinicians that for some patients can use, like the Verticare vibrators. They can use them themselves, but quite often there may be a sexual function clinic, perhaps within a spinal center, that might be linked to a fertility clinic. So the two sort of work hand in hand. And we see a lot of success. We see a lot of patients that do go on to have children following their spinal cord injury. But it's not just the physicality of the mechanics of how spinal cord injury affects erections, but it's looking at how can somebody be intimate with their disability. And there are various aids out there that can help that. And just at the top, this picture here, it's called an intimate rider. So the chair itself has like a sort of rocking function, so it can give that sort of rocking motion when it comes to intercourse. It might be that the partner lays on this, which looks like sort of a camp bed here, to enable the partner to be in the right position for the person with the disability. And things like these, it's called an inflatable position master, which essentially is it's a wedged inflatable cushion. So it can just help the person with a disability, or even the partner, just to be able to get into the right position in order to have penetrative sex. And just on the right hand side here is just it's a masturbation device. It's called a Pulse Solo Essential, and cost wise they vary in price. The Intimate Rider is just under £500. This masturbating device is about £75, but the inflatable cushion is about just under £27. I've left this website here, or just this is the details of a website called Spokes, which has a lot of information about having sex with a disability, and just some of the other equipment that can just make that whole process that much easier. So on that note, that sort of concludes what I have just to explain about sexual function when it comes to men with a spinal cord injury. So I'm going to stop sharing my screen, and and just open it up to any questions if anybody's got any questions at all.
Hi, well, thank you so much for all of that, Damian. I mean, I have some obvious questions about that Pulse Plus device as a result of all of this, and it's interesting to see all the equipment at the end and get those recommendations. But what is coming through on the questions is basically where to go for advice, whether for people who are currently in SCI centres or people who've been discharged. Where should people go if they have specific questions?
Sure. So if anybody's got any questions about, sexual function, or, where to go to, if they are under the care of a spinal center, they can go to, their outpatient team, where the outpatient nurses should be able to answer a lot of their questions. If it's to do with, trying equipment with a view of fertility, again, they can go to their spinal center and speak to their consultants there. If it's just to do with, sexual dysfunction, how to get an erection, they can speak to their GP. Often we would be advising that the GP refers them to a urologist, because, it's those same nerves that affect the bladder that affect sexual function. So quite often a urologist is the best placed person to talk about sexual function.
And that's just going to your GP and having a chat and asking for a referral.
Yeah, but in the first instance, if you've got someone that isn't under the care of the spinal center, they can come to us, the Spinal Injuries Association. We have 5 spinal cord injury nurse specialists now. We will have a 6th person next month. So I think between the 5 of us, we've got about 125 years of experience of spinal cord injury nursing, and I would never claim to know everything there is to know about that, but I think if we don't know the answer, we know somebody that will have the answer.
And I've just seen Michelle Donald, who's our speaker in a few weeks' time.
Hi, Michelle.
And, say that you could go to a psychosexual therapist. I think obviously we've been so focused on the physicality today, and that was your remit, but and you touched on quite a lot of the emotional and psychological hurdles, but we've got later in the series, we're going to be covering up some of those. I've got a specific question here about Viagra and other medication. Is that something that a GP could deal with, or do you think specialist advice would be needed?
No, absolutely. GP first port of call. So I think they're a lot more familiar with the medications now, because it's not just for somebody with a spinal cord injury. It might be someone with diabetes, for example, that has issues with sexual dysfunction, someone that's had prostate surgery, for example. So GP would be the first port of call. These aren't unusual medications. They are sort of very commonplace, but I think the important point is, to make sure that they do read the instructions on the packet. So it's not just a matter of you take the tablet and then you just miraculously get an erection. It does still require that physical stimulation as well. And if it is Viagra, to make sure that it's taken on an empty stomach, so that you can avoid a lot of disappointment, if it is taken in the correct way. But go to the GP in the first instance. And for those patients that are under the care of a spinal center, this should be a question that is asked each time, as part of a general assessment. When they're talking about their bladder, their bowels, their skin, their respiratory function, the question should always be asked about sexual function as well, at least to give somebody the opportunity to talk about it if they want to.
I think as well, for a lot of people, I can imagine that your focus on your sexuality can change over time after you've had a spinal cord injury, and you might be discharged from care, and it's about getting that advice. Even if you've been asked at that time, it's about getting forward to ask that advice and know where to go. So it's really good to hear you say that you'll be more than happy to accept any questions yourself. I just encourage people to get those referrals and approach people like Michelle for advice. I've got another specific question here from Sue Lennon. I appreciate we've gone over slightly. If we just hold on to you for a few more minutes.
That's okay.
Questions. So if a spinally injured man receives anal penetration, can that trigger AD? And if so, can it be pre-treated?
So the simple answer is, if they've got a spinal cord injury of T6 level or above, then potentially it could trigger autonomic dysreflexia, because autonomic dysreflexia is the body's response to pain or discomfort that the body can't feel. It's the body's interpretation of that pain or discomfort. So it might be that particular patient, if they have to manage their bowels through manual evacuation or digital stimulation, they might already have an inkling as to whether, if that causes a dysreflexic response, then potentially anal sex will cause a dysreflexic response too. If that is the case, what can they do to sort of mitigate against that? You can use things like a lignocaine-based lubricant gel, which just numbs the bowel mucosa. So that's all quite common practice when it comes to, the reducing the trigger of autonomic dysreflexia through digital stimulation. So by numbing the bowel mucosa, essentially you're desensitizing that area, which reduces the trigger for autonomic dysreflexia. If you've got someone that has sensation, then they're less likely to experience autonomic dysreflexia because those nerve pathways are intact. So primarily we're talking about someone that's got a complete spinal cord injury. But the answer to the question is yes, anal sex could trigger autonomic dysreflexia, but equally there are ways to manage it as well through things like, a lignocaine-based gel to numb the bowel mucosa.
That's really good full answer. Thank you. I've before tying everything up, one question that has come through on the chat is the key piece of advice that you personally feel that you would give anyone who is maybe struggling with the idea of sex or their sexuality after a spinal cord injury.
I think the key piece of advice is that, don't be afraid to ask. I think knowing that there are people out there that will happily talk to somebody about sexual function, sexuality. I can impart my experience of 26 years of spinal cord injury nursing, but also as well, it might be that if there are any specific issues that, we could put people in contact with other people that have that lived experience. Our support coordinators are quite happy to talk about, pretty much any aspect of spinal cord injury. And it's not just, the Spinal Injuries Association. We work closely with other organizations like the Backup Trust, Aspire. They all have people with spinal cord injury that are equally happy to share their lived experience as well. But I think, what we can do is dispel some of the myths that they might have heard, or dispel some of the anxieties that they might have. So the take-home message would be, if you've got any questions, just ask. And hopefully, if you're under the care of a spinal center, we can initiate that conversation with you as well, by covering it as part and parcel of your routine assessment. So the take-home message is, can I still have sex? Yes, you can. Will your spinal cord injury affect it? Probably will, in different ways. But if we know what your spinal level is, then we can identify what the best options are for you.
I think that's it. But the only way to identify it is to start the conversation. So your key piece of advice being start that conversation resonates. And I think that's the key piece of advice from a presentation on the physical aspect, starting a conversation. And as we work through the webinars, starting a conversation and open communication will be something I think that keeps coming up again and again and again. It's definitely something that Michelle's going to be talking about in a few weeks' time.
Yeah.
I think as a society, we just do not talk about sex enough, and something that comes out from organising these webinars is that to have a fulfilling sex life is probably a good idea to have like open communication about and around sex, and it's really difficult for people to do. But some of the stories that will come out in a couple of weeks' time when we have the spinal cord injured guys come and have a chat about the process they've gone through, and it's such a wide range of experience from people, spinal cord, different levels of spinal cord injury, different kinds of sexual dysfunction, sex with an erection, sex without an erection, anal stimulation, toys, to hear people talk about like sex lives that would make that alpha man who's out in the pool jealous, yeah, I don't know.
Yeah.
Ashamed perhaps of his Neanderthal ways, and it raises questions about gender roles and what sex is and what we want sex to be and what sex is projected as society on all of us, and that's all through the prism of people sustaining a spinal cord injury. So I'd encourage everyone who has come along today to come along in a couple of weeks' time, including Damian, who I think will be there.
Thank you.
And thank you once again for your excellent presentation.
Thank you. And what I would just say, just right at the very end, is that we've talked about the physicality of sexual function today. You know, sex doesn't involve necessarily intercourse. You know, sex can also just be, you know, how you're intimate with your partner, and you know, it can be exploring other ways that, you know, might turn you on. So it's not just all about that physical process of intercourse. You know, there are, you know, it encompasses a whole lot more. But yeah, if anyone's got any questions, just ask, and yeah, if we can help initiate that conversation as well, I'm very happy to do so.
Yeah, amazing. Any questions? A few people have asked for your slides, so if you wouldn't mind forwarding them on. And I've got this presentation will go up on our website in the next couple of days. So please do circulate to anyone else you think might be interested. I'm sure everyone's giving you a round of applause, so thanks very much.
Thank you. No, much appreciated. I appreciate everybody else's time as well for coming along today. But I'll get the presentation to you, Tom, and then whoever wants a copy, yeah, by all means, just disseminate it. All I would ask, though, very kindly, is that you know, we might use some of these slides for our own education sessions. You know, if anybody wants to use them, please just contact us first.
Amazing, perfect. Thanks so much.
Thank you very much. Thank you.
Bye bye.
Thank you.